Hello, welcome back to Dental Notes and Mnemonics. Today we'll be discussing about the wound healing after tooth extraction. Tooth extraction is one of the most common dental procedures. It leaves behind an open wound in the jawbone or soft tissues. The body immediately begins a complex healing process to restore the sight. But how does it happen? What are the stages and what factors influence the healing? Let's break it down step by step. Healing happens in four stages after the tooth is removed. First stage is hemostasis or coagulation, where the blood clot forms to stop the bleeding and protect the socket. Second stage is inflammatory stage, where the body defense system removes debris and prevents infection. In proliferative stage, which is the third stage, a new tissue and bone begin to form in the socket. And in the remodeling stage, which is the fourth stage, the bone gradually strengthens and reshapes, a process that can continue for years. We'll be discussing all these stages in detail in coming slides. After a tooth is extracted, bleeding occurs immediately and a socket fills with blood. This leads to formation of blood clot, which contains red blood cell, white blood cells, platelets and fibrin. The clot serves two important roles. First, it stops the bleeding, and second, it creates a base for healing. Within first 7 days after the extraction, this clot is gradually replaced by granulation tissue, which is made up of newly formed blood vessels, mesenchymal cells and immune system. During this, the blood clot releases growth factors and cytokines, which activate the next stage of healing, that is the inflammatory phase. Dry socket affects the early healing stage, particularly the hemostatic phase only, and there is a failure of clot formation. So if the clot does not form properly due to excessive fibrinolysis or mechanical dislodgement, healing is disrupted. And premature clot loss prevents the granulation tissue further in coming stages. Exposed bone leads to severe inflammation and pain, and bacterial colonization can further aggravate the inflammation. Now coming to the inflammatory stage of socket healing. After the tooth extraction, the inflammatory stage of socket healing begins within 48 to 72 hours. In the early phase, neutrophils arrive first, helping to remove the blood clot and fight off the potential infections. They are guided by the platelet-derived growth factors and interleukin-1, which signal the immune system to respond. As healing progresses, macrophages take over and release growth factors like vascular endothelial growth factor and fibroblast growth factor. These factors help in the formation of new blood vessels and a connective tissue, paving the way for the further healing. Mild to moderate discomfort, throbbing or dull ache manageable with the medication is normal during the healing process after extraction of a tooth. Severe, sharp or worsening pain after few days can indicate dry socket or infection. This pain, swelling also peaks around day 2 to 3 and it gradually decreases by day 4 to 5, and after 1 week most of the swelling should be gone. But if there is rapid increase, redness, spreading or pus, fever, which is a sign of infection, then it is considered to be an abnormal swelling. And by the end of 4th week, the blood clot is replaced by the granulation tissue, which is rich in new blood vessels, fibroblast and inflammatory cells. This marks the transition to proliferative stage, where the new bone and soft tissue formation begins. Proliferative stage is primarily focused on tissue formation and repair. This stage lasts about 4 to 24 days and it involves several key processes. First of all, there is fibroblast migration. They move into the wound site, attracted by the growth factor like platelet derived growth factor and transforming growth factor beta. These cells play a very important role in collagen production and extracellular matrix formation. Fibroblasts also begin producing type 3 collagen, which serves as a temporary scaffold for wound strength. Later, this collagen is replaced with the stronger type 1 collagen in remodeling phase. New blood vessels are formed from pre existing ones, ensuring adequate oxygen and nutrient supply to the healing tissue. This process is driven by vascular endothelial growth factor and fibroblast growth factor. The other factors which are involved in angiogenesis is the platelet derived growth factor, angiopoietins, transforming growth factor beta, and hepatocyte growth factor. But out of all these, the vascular endothelial growth factor is the most important one for angiogenesis. After that, there is a formation of granulation tissue, which is a soft pinkish red connective tissue composed of fibroblast, new capillaries, and extracellular matrix, which fills the wound, and it provides a foundation for further healing. Also, keratinocytes proliferate and migrate from the wound edges to cover the defect. This restores the skin barrier and prevents the infection. After that, myofibroblast, which are specialized contractile cells, pulls the wound edges together, reducing the wound size. So till now, the temporary provisional matrix, which is deposited by the fibroblast, is rich in collagen fibers, blood vessels, and mesenchymal cells. After that, there is a formation of woven bone. Woven bone is the first type of bone that forms when the new bone is made. It may be due to growth or healing both. It is called woven because its fibers are arranged in crisscross pattern just like a woven fabric. The woven bone gradually replaces the granulation tissue or any remaining periodontal ligament fiber, and by the week 6 to 8, most of the granulation tissue is replaced by a woven bone, forming a solid base for further bone development in the later stages. Important factors here are the bone morphogenetic proteins and transforming growth factor beta, which plays a key role in osteoblastic differentiation. The final stage of socket healing involves modeling and remodeling of the bone to ensure the replacement of woven bone into a mature lamellar bone and the bone marrow, giving the bone the load bearing capacity. This may take several months to a year depending on the individual healing responses. There is a difference between modeling and remodeling. Modeling refers to the change in the bone shape and structure which occurs as the alveolar ridge undergoes resorption, and remodeling is a process of bone formation without altering the overall structure of the bone. So, if we talk about the bone healing timeline, by the second week, a woven bone starts forming around the blood vessels, creating a scaffold. By the week 6 to 8, this bone replaces the granulation tissue, strengthening the area. By 10 to 12 weeks, this bone hardens or mineralizes into a solid structure, and by the week 12 to 16, a woven bone transforms into a stronger lamellar bone and marrow. And beyond 24 weeks, continuous remodeling ensures long-term bone strength and its stability. Remodeling of alveolar socket is driven by two key type of bone cells. First is osteoblast and osteoclast. Osteoblasts are the bone forming cells, and osteoclasts, these cells break down the old bone, allowing for reshaping and adaptation. Bone healing is controlled by several growth factors which regulate the formation, mineralization, and remodeling of bone. First, RUNX2 and Osterix, they play a crucial role in osteoblast differentiation. That means they help to convert the immature cells into bone forming cells, and without them, new bone cannot form properly. Next, as the bone matures, osteocalcin and osteopontin step in. These proteins aid in bone mineralization, making the newly formed bone stronger and more stable. Finally, to maintain a balance between the bone formation and resorption, a rankel, and OPG, that is osteoproterogen system, comes into play. Rank and rankel ligand promote the bone breakdown, while osteoproterogen act as a protective factor, preventing excessive bone loss. Together, these growth factors ensure that the bone heals efficiently, becomes stronger, and adapts to the functional demand over the period of time. Let's discuss the changes in the alveolar socket after the tooth is extracted. The bundle bone, which directly supports the tooth, is first to resorb, leading to overall rich shrinkage, and it is most significant within first 6 months, followed by a slower continuous resorption process. The buccal and the labial bone resorbs faster than the lingual and the palatal bone, because the buccal bone is thinner and making it more vulnerable to loss. If we compare the horizontal and the vertical changes, then the horizontal changes are more as comparison to the vertical changes. So width decreases more as comparison to height of the alveolar ridge. If we look for the regional variation, then the molar region resorbs more than the premolar region, and it is more pronounced in the mandible compared to the maxilla. Let's discuss the factors which affect the healing of socket. First of all, the local factors include the molar extractions, especially the mandibular molars, shows a more irregular healing and greater bone resorption than anterior teeth. Regarding the extensive procedures such as flap elevation, can disrupt blood supply, slowing healing and increasing the bone loss. Regarding the number of the edentulous sites, extraction of multiple teeth will always lead to greater resorption than the single missing tooth. Systemic factors include the smoking, as the nicotine in smoke reduces the blood flow and bone healing, causing more alveolar crestal bone loss in smokers. In case of diabetic patient, especially when there is uncontrolled diabetes, it delays the collagen formation, slowing healing and increasing the bone loss. In case of postmenopausal osteoporotic patients, lower bone density results in ridge resorption, affecting the maxilla and the mandible differently. Some iatrogenic factors may also be involved determining the wound healing. Surgeon's technique, if there is excessive force or poor surgical handling of the tissues, it can damage the alveolar bone, leading to increased resorption. And other therapeutic or environmental factors are hyaluronic acid application. It involves early healing by promoting cell migration and differentiation. Chlorhexidine mouth rinses may reduce the bone resorption, though the mechanism remain uncertain. Also, the hypobaric oxygen therapy enhances osteoblast activity and it limits bone loss, aiding in ridge preservation. Also important to know here that why do the wound healing is slow in diabetic patient. We'll be discussing this with respect to all the 4 stages of normal wound healing. Till now, we all are aware that wound healing occurs in 4 stages. The first is hemostasis, inflammation, proliferation and remodeling. In normal wound healing, it progresses efficiently, but in diabetic patients, cellular dysfunction delays each stage. Clot formation is slower due to platelet dysfunction, leading to prolonged bleeding. The inflammatory phase is prolonged because the immune cells such as neutrophils and macrophages are impaired, increasing the risk of infection. During proliferation, fibroblast and endothelial cells function poorly, slowing the new tissue formation and blood vessel growth. Finally, in remodeling phase, defective collagen synthesis and abnormal fibroblast activity results in weaker tissues, increasing the likelihood of chronic ulcers. So, managing diabetes through glycemic control and specialized wound care is essential to improve healing outcomes. So this was all about the wound healing after the extraction. Thanks for watching the video. Hope you like it. And don't forget to like, share and subscribe for more videos like this. See you in the next video. Till then, bye bye. Take care. Have a nice day.